This week on the BackTable podcast.
Think about the fact that patient's just sitting in a bed. Yep. That's 10 grand a day just sitting in a bed. So, and depending upon the patient's comorbidities with an open bypass, they may be in the hospital from anywhere to 2 to 5 days. So the fact that you can get these people home the next day and that they're able to resume all their functional activities within just a couple of days really gets them back to a fully functional status in just a matter of a couple of days.
Hello, everyone, and welcome to BackTable, your source for all things endovascular and more. You can find all of our episodes online on any platform you prefer, like Spotify, Apple Podcasts, or directly through our website, backtable.com.
First, a quick word from our sponsors.
Today's BackTable podcast is brought to you by our sponsor, Endologix, a global interventional vascular company dedicated to providing disruptive therapies for patients with vascular disease. We are thrilled to share the latest breakthrough in the treatment of complex PAD. As physicians, you understand the challenges faced by patients with long, complex SFA disease. At present, patients with long blockages of the SFA have limited treatment options. The recommended therapy is open surgical bypass, which is invasive, has a high early complication rate, and requires prolonged recovery. Endovascular treatments are feasible in selected patients, but have limited patency. Percutaneous transmural arterial bypass, PTAB, with the DETOUR system is a unique therapy that provides a fully percutaneous femoral popliteal bypass that is routed through the femoral vein to restore blood flow to the leg. The DETOUR system represents a significant step forward for patients with lesions ranging from 20 centimeters to 46 centimeters in length. Join us on today's BackTable podcast for an in-depth discussion on this paradigm-shifting therapy.
Now, back to the show. I'm Sabine as your host today, and I'm excited to welcome Dr. Peter Soukas, an interventional cardiologist at the Miriam Hospital and Brown Medical School in Providence, Rhode Island. Welcome, Peter.
Thank you very much, Sabine. It's really a pleasure to be with you.
Oh, yeah. No, it's really, the pleasure's ours because it's going to be nice to know your point of view on today, which we're going to talk about percutaneous bypass. There's been a lot of talk. We did one episode on this before too, but people have a lot of questions about the procedure, the outcomes, and more about the device. So I'd love to kind of delve into your brain. Before that, though, I want to hear a little bit more about yourself. How did you end up in Providence? And tell us a little bit about your practice.
So I'm actually a Rhode Island native, and I went to college and medical school in Boston, did my cardiology and vascular fellowships in Boston, interventional cardiology in Ann Arbor, Michigan, and was in practice in Boston for many years, and then was recruited back to Providence in 2010 to establish our vascular medicine fellowship program. And I've been the director since 2010. So after a lot of years, the prodigal son finally returned home to Rhode Island.
Yes. How did you have an interest in vascular medicine, like the vascular side of medicine and everything from your training? Did you know you wanted to be the director? How did that come about?
So I had the great fortune of training under two incredible pioneers in the field of vascular medicine, Dr. Jeff Isner and Dr. Kenny Rosenfield. And I was with them from 1990 to 1993 when I did my general cardiology fellowship, and then returned to St. Elizabeth's in 1999 to do a vascular fellowship because I really wanted to expand that part of my practice. And I became very interested in endovascular, which back then was kind of like the wild, wild west. And it has really been the main focus of my career. I am probably about 95% of my practice is vascular and endovascular medicine based.
Okay, great. So that was going to be my next question. How much endovascular peripheral are you doing versus, cardiology, coronary interventions?
Yeah, I do coronaries when I'm on call, but the rest of my time is pretty much dedicated to vascular.
Okay, awesome. And how many people are in your practice?
So in our cardiovascular institute at Brown, we have over 45 cardiologists in our practice. And obviously that includes general cardiologists, as well as imaging folks, EP, and our structural colleagues and interventional colleagues. We have 6 general cardiology fellows per year. We have 4 interventional fellows per year, as well as a dedicated structural fellow and dedicated peripheral fellow. And then we also have 2 EP fellows per year as well.
Oh, yeah. That's big.
So
it's
lots of fellows.
Yeah, lots of trainees that you guys are doing that you're pumping out. So percutaneous bypass, PTAB for short. What does it stand for? What is it? And when did you start incorporating it into your practice?
So PTAB stands for percutaneous transarterial bypass. And it was a concept that was born by my friend and former partner, Jim Joy. Jim and I actually started our careers together at Allegheny General Hospital back in the mid-90s. And Jim really developed the concept and also worked with Rich Heuser to bring it from the napkin stage to a commercially available product. And when you think about it and when you look at it, you're like, gosh, why didn't I think of that? What a brilliant idea. And it really has become, I think, a disruptive technology because it addresses a lot of the problems with endovascular therapy, particularly for these really long, complex lesions. As you know, the overwhelming majority of the toughest cases that we deal with are type C and D lesions. Oftentimes, they're incredibly calcified. Oftentimes, they're very long CTOs. And although we've made great strides in crossing both antegrade and retrograde techniques, SFA access, the fact of the matter is that these really long, complex lesions unfortunately do have limited durability. And so the idea here was to basically bypass all of that bad stuff and be able to create an endovascular conduit that could be created in a less invasive percutaneous fashion.
Perfect. What is that conduit? Can you kind of just explain to our listeners
Sure.
How is it defined?
So the concept here is to basically replicate a prosthetic fem to above knee bypass procedure. So instead of making open incisions, the procedure basically involves an up and over approach with delivery of an 8 French sheath from the opposite common femoral artery. And then concomitantly, we're obtaining ultrasound guided access, typically in the ipsilateral posterior tibial vein.
Okay.
So we insert a 6 French sheath into the vein, and then we are bringing our sheath up and over into the common femoral artery. And then we're basically creating a proximal anastomosis from the proximal superficial femoral artery into the femoral vein. And then we're going down into the distal femoral vein and then creating another anastomosis, this time from the femoral vein into the above knee popliteal artery, basically dilating both of those areas and then delivering typically 3 overlapping self-expanding stent grafts to basically bypass the diseased native SFA and creating a new conduit utilizing the femoral vein as the method by which we can deliver those stent grafts to create a new route for that blood to go into the distal leg.
Got it. So how are you actually crossing from the artery to the vein? Where do you determine to cross it? And where do you determine how to land it too? Like where in the popliteal do you re-enter?
Right. So we're typically using the dedicated reentry device from Endologix. It's called the EndoCross. And I like to joke that this is an Outback on steroids. It is differentiated from other needle reentry devices in that it is spring-loaded and it has a quite long reach. It's a 15 millimeter reach. It's a 0.025 inch needle. And there are markings on the distal tip of the catheter, which I affectionately refer to as hieroglyphics. But the hieroglyphics are designed to allow you to know where you're going to be deploying that needle. And what we typically like to do is orient the femoral artery and the femoral vein such that we're making the proximal anastomosis from the proximal SFA into the proximal femoral vein in a posterior direction. Now, we have, of course, by this time, delivered a snare from the ipsilateral posterior tibial vein access, which is typically a 6 French sheath. So we have a snare at the ready to accept our 014 wire. So after orienting the device, we basically hit the button and that propels the needle forward. And we then will advance our 014 wire into the waiting arms of our snare. So we then will capture that wire and then basically bring that wire down into the distal femoral vein. And then essentially, we're going to do the same thing to create the distal anastomosis. Now, before we do that, we do typically dilate that proximal anastomosis with a 4x40 balloon to just make room to deliver the endocross distally. And then we essentially do the same thing, but this time we're going from the femoral vein into the above knee popliteal artery. So after we have delivered our endocross into the distal femoral vein, we are essentially lining up the artery and the vein so that they're superimposable. And then this time we're orienting the device typically in an anterior position. And then again, fire that needle and then deliver that 014 wire into the distal tibial artery. Now we like to try to get a lot of purchase into the distal tibial artery. We typically do like to use a wire that has some body to it, a Spartacore wire or a Grand Slam. And then once that wire has been successfully delivered into the distal tibial artery, we then retract the needle and then walk the device out. And then typically a fresh new 4 millimeter balloon is then used to dilate the distal anastomosis. The anastomosis can sometimes have recoil, and occasionally we may upsize to a 5 millimeter balloon, or we'll use a scoring balloon like a cutting balloon or a serenader to sort of help defeat that distal recoil that can sometimes happen at that distal anastomosis. After we've created both of the anastomoses, we'll then deliver a 0.035-inch support catheter, again, as distal as we can into that tibial artery, switch out the 014 wire, and then put a very supportive 035 wire in. I personally like to use the SuperCore, but other folks like to use, for example, a Amplatz super stiff wire. And that's really the hard part of the procedure. The rest of it actually is pretty quick and easy. Basically, we then will deliver our torus stent grafts, and these are very robust stent grafts. They have a lot of crush resistance, and that's, of course, an important attribute to prevent any recoil, particularly at the anastomotic sites. And more often, we will usually deliver 3 overlapping stent grafts.
Okay. So a couple of questions, actually a lot of questions here. So as far as re-entering into the popliteal, a lot of times with these really bad femoral SFA calcified lesions, the lesions extend into the proximal popliteal. Are most of these cases, are your pops pretty clean that you're entering into? How many of them have you done now that you've got, fine, it doesn't have to be really bulky disease, but pretty calcified disease in the P1?
Yeah, so I think on the basis of the prior duplex that the patient may have had, on the basis of the CT scan, you pretty much know where the bulk of that nasty calcium is located. And that, I think, is really helpful in deciding where you want to enter. And that's a great point, that we don't want to try to re-enter in an area of heavy calcification. So in a situation where you're faced with distal SFA and P1 segment calcification, we'll typically try to re-enter distal to that nasty calcium so that we can hopefully find a nice soft spot where we can re-enter the vessel. That is something that we have learned, that calcium is to be avoided if at all possible. And I would rather go a little bit more distally to avoid that calcification. It's just going to make the rest of the case a lot easier.
Yeah, I can imagine. I mean, once you get back into the artery, even just passing your 4 millimeter balloon to dilate the tract can be hard if it's a really calcified artery. And then,
sure.
Yeah. I mean, how many times do you run into wrong? Yeah.
Yeah. Thankfully, it doesn't happen that often. The beauty of the endocross is, again, because it is spring-loaded, it does have the ability to get through those calcified arteries really quite readily. And just like with any other reentry device, because it does have a longer throw, you may actually be through the back wall. So our typical technique is to very gently advance the wire. If you feel any resistance, then basically just very slowly and carefully bring that needle back while you're sort of probing. And typically what happens, Sabine, is that wire will then kind of just shoot forward into the true lumen. And then at that point, we typically will withdraw the needle altogether once we've secured good distal wire access.
Got it. And we see paired femoral veins a lot, when we do lower extremity venograms and intervention. What in that case, how do you decide which femoral vein to use? Do you just figure out whichever one's the closest or the bigger one, or how, and what are some size limits?
Yep, that's an important point. So in the study, that was actually one of the exclusion criteria, was that you had to have a femoral vein of at least 10 millimeters in diameter, or you had to have a duplicate vein. Now, the reason for that is fairly intuitive. We want to make sure that there's some room in the vein for both blood to flow back in a cephalad direction, but also to be able to accommodate the stent grafts themselves. So you have to have either a femoral vein diameter of greater than 10 or a duplicate femoral vein. We typically like to go for the biggest target that we can. And so we will always try to choose, in a situation of duplicate femoral veins, we usually try to take the bigger vein, and that will be the conduit through which the stent grafts will be delivered.
Got it. And you mentioned the torus grafts they have a lot of radial force. Are they hard to deploy, or is it pretty simple, the deployment system?
No, the deployment is very simple. It's just the torus stent grafts have a lot of crush resistance, but the deployment mechanism is really quite simple. You basically are just turning the wheel counterclockwise to deploy the stent, as is common with a lot of the other stent delivery platforms that are commercially available. And again, the key is to have a lot of overlap, typically 4 to 6 centimeters. Now, one of the questions that comes up a lot, Sabine, is what about that final stent graft? So ideally, we like to have at least 3 centimeters of stent graft in the popliteal artery, so we have a good distal purchase, but we also want to have the same on the proximal end. So we like to have at least 3 centimeters on both ends. And what I like to do is, when I'm deploying my final stent graft, I like to come ipsilateral, like 30 to 40 degrees. I really want to lay out the bifurcation of that common femoral into the SFA and profunda, because we want to be aggressive about the placement of our final stent graft. We absolutely want to make sure that that stent graft is covering the entire ostium of the SFA. And in fact, we like to cheat a little bit and actually maybe even have 1 or 2 millimeters covering the bottom portion of the profunda. Remember, the top 5 millimeters are bare stents, so it's perfectly okay to have those bare metal stents in front of the profunda ostium.
Perfect. Yeah. And a lot of times with these calcified lesions, they're going pretty proximal. I mean, fine, not a flush SFA occlusion, but pretty near the ostium. Are you ever going to get that 3 centimeters of proximal SFA? Are you going subintimal at all ever, and then using the crosser to go into the vein, and then going back into a better patent popliteal?
Yeah, that's a great question. So in point of fact, we want to establish that 3 centimeter beachhead, if you will, for the proximal SFA. Now, sometimes if that's a tiny little beak or a tiny little nubbin, then we will purposely go subintimal for a few centimeters into the SFA, and then balloon that so that we can actually have a platform, a landing zone, if you will. So that's not at all uncommon if we have an essentially flush occlusion, is that we will balloon that fairly aggressively so that we can have a runway, or if you will, a landing strip for that last proximal stent graft.
And the sizes of the graft, are there a lot of sizes available to accommodate for a smaller big pop or a bigger SFA?
Right. So for the study, we had to have vessel sizes that were at least 4.5 millimeters in diameter and no more than 6.7 millimeters on the proximal end. And that was basically to accommodate the stent grafts that were available and still are available. So they are available in 5.5, 6, and 6.7 millimeter diameters, and they have lengths of 100, 150, and 200 millimeters.
Okay. And again, you just choose the lengths based on you're using 3 usually with 4 to 6 centimeters of overlap each.
Yeah, every case that I've done, I've always ended up using 3 stent grafts.
Okay. Now, a lot of skeptics out there are asking, why percutaneous arterial bypass? Why use the vein? Why put a device in the vein when these conventional techniques have worked, where you've gone retrograde, antegrade, recanalize this nasty SFA? How do you convince these skeptics that this is something worthwhile to try?
Well, it's a valid question. And I think as endovascular operators, we have to be honest and really take a very careful look at the results of native and subintimal interventions, particularly when you're talking about long CTOs, task C and D lesions, when you're talking about calcified lesions. And we oftentimes can get through these nasty 30, 35 centimeter calcified CTOs. And we've gotten very good at crossing both antegrade, using a variety of techniques and reentry devices. And then, of course, I think a lot of us have become really quite facile and very comfortable doing retrograde access from a pedal approach, or even a distal SFA or a proximal popliteal approach. The problem is not the acutely getting through the occlusions. The problem is being able to get a really good expansion of the artery and restore brisk laminar flow. How many times have we had cases where we've banged away for 2 to 3 hours and we're ballooning the heck out of that SFA, and then we're putting in stents, and then we post-dilate the stent and we end up with a hourglass appearance to the stent. You've got a 50% residual stenosis after you've banged away at it and used a high pressure balloon. I think we all know that that patient is not going to have a very good and durable outcome. And so this technique, I think, is not for patients who have type A and type B lesions, but rather these are patients who are, the fugly uglies, as I like to call them. These are the cases where we know we're going to have a long time. It's going to be difficult getting through it. We're probably not going to have a great acute luminal gain. And we know that these are the folks who typically are going to have a high likelihood of restenosis, vessel closure. So PTAB is really reserved for these more difficult, more complex, more calcified lesions. Now, I think we have to also admit that for patients who are not great candidates for an open bypass, either with prosthetic above knee pop or with vein, there are an awful lot of people out there who have coronary artery disease, who have advanced liver or kidney disease, who are not going to be very good candidates for conventional open bypass. So this is obviously a much less invasive approach, and I think a very safe approach for those patients. We've also had plenty of patients in our practice who are frequent flyers. We've done all kinds of interventions, and they've been back to the lab multiple times, and they have in-stent restenosis, or even worse, they have stent fractures with displaced stent segments. These are patients, obviously, who have very limited options. So the beauty of PTAB is that you can avoid all of that nonsense and just simply go around it. And the other fact of the matter is that for lesions where it's super duper calcified, where you know you're not going to be able to get a good luminal expansion, I think this is another very good alternative way to deal with these, again, typically task C and D complex long lesions.
Got it. In your kind of patient selection, are you doing PTAB de novo, meaning that you know that you're going into the case, you're going to do it, or do you try the endovascular approach first? Do you do a diagnostic angiogram, or we mentioned doing preoperative CTA? How are you selecting and how many times are you just going de novo or you're going to go PTAB?
So this is obviously something that's still a moving target. And in the beginning, we were very, very careful about who we offered this therapy to. And I would still recommend to folks who are going to be adopting this into their practice that they should probably try to stick with the IFU and stick to the cases that we did in the DETOUR 2 study, both in terms of their inclusion and exclusion criteria. So patients who have long complex lesions, patients who have long calcified lesions, patients who have failed prior endovascular therapy, these are all patients who I think are great for this particular procedure. So those are the patients that I'm going to consider right out of the gate for a PTAB. I mean, we have all had cases where we've spent 3, 4, 5 hours getting through and then been disappointed in the end. So in my practice right now, the patients that I'm considering for PTAB primarily are patients who have task D lesions that are more than 20 centimeters, especially if they're calcified, provided, of course, that they have a good popliteal artery with at least one tibial that's disease-free to have good tibial runoff. And of course, they also have to have a femoral vein of at least 10 millimeters or a duplicate femoral vein. And the other patient characteristics that I think are important to remember is this is a conduit that is going to require antiplatelet therapy for at least 3 years. Those are the recommendations and requirements for the study. Now, in light of the Voyager and Compass trials, we're now incorporating systemic anticoagulation as well. So in my mind, you need an antiplatelet agent, for example, clopidogrel or ticagrelor. And if a patient has a mechanical heart valve, if they have AFib, or if they've had a prior history of VTE, and they need to be on systemic anticoagulation, then we have simply done clopidogrel with their systemic anticoagulation. If they don't have AFib, but if they have diffuse panvascular disease, again, we know from the Compass and Voyager PAD studies that these are patients who probably, in fact, would benefit from low-dose rivaroxaban. And I think a lot of us are moving to a regimen of low-dose rivaroxaban and clopidogrel, provided that the patient has adequate insurance to cover the medications and that they don't represent a high risk for bleeding. So that is what I am moving to as sort of my default strategy for DETOUR patients is low-dose rivaroxaban and clopidogrel.
And during the procedure, I'm assuming you're heparinizing to, 200 to 300 ACT, being that you're putting all these devices in the femoral vein. How many times, the biggest question, again, it goes with the skeptics, is you're putting a device in the femoral vein, leaving it there. What is your rate or how much have you seen of DVT occurring after this procedure?
Yeah, that's an important point. So in the DETOUR 2 study, the rate of DVT was 4.1%. Fortunately, there were 0 pulmonary emboli.
Mm-hmm.
And in the long-term follow-up, so far, there have not been any additional cases of DVT or PE. Sean Lydon will be reporting on the 3-year results of DETOUR at the Vascular meeting in June. So we'll have even better long-term data to report as far as venous stents are concerned.
Okay. And right now we have, did you say it was 2-year data that we have that available right now? And 3 years going to be
so
presented?
We have 2 years going to be presented later.
What's the patency at 2 years? So someone who wants to, okay, they decided, especially maybe after listening to this episode, they want to get PTAB into the hospital. First of all, we've talked about a lot of devices, crosser, 3 stents. I'm assuming that the product itself is pretty expensive. How is this procedure reimbursed? Has its own code? Do they have any additional codes that help with covering the cost of the device?
Yes, they do. So in point of fact, the device is a global price of $25,000. Now, obviously that does sound like a lot. And I'm not saying that it's cheap, but for example, LimFlow is also $25,000. But important to remember, and especially to tell your hospital administrators, that there is a new technology added payment code, and there is also a transitional pass-through payment as well. So for our last case, I believe that the total payment was about $32,000. So that obviously covers the cost of the device. And of course, you're going to throw a snare in there and a couple of balloons. But the bottom line is we didn't lose any money on that case. Now that the additional payments started actually in January of this year. So now that we have the additional payments, it should not be a money loser for the hospital. If anything, they may actually make a little bit.
Got it. And is this pretty much hospital-based only? Is it open to outpatient surgical centers, OBLs, or that's kind of in the future for this device?
Well, actually, there is a code for APCs. That code is 5193. Mm-hmm. The payment with the transitional pass-through is about $30,000.
Okay.
So it is available to be used in an ASC setting. There is no specific payment or code for an OBL. Most of the patients have had inpatient one-night stays. In the study, for example, the average length of stay was only 1.1 days. Obviously, that's a big difference compared to an open surgical bypass.
Yeah, yeah, and that's huge, right? Those are the cost savings that you can see big time for hospitals and lengths of stay, which everyone's all obsessed with these days.
Right. I mean, think about the fact that patient's just sitting in a bed. Yep. That's $10,000 a day just sitting in a bed. So, and depending upon the patient's comorbidities with an open bypass, they may be in the hospital from anywhere to 2 to 5 days. So the fact that you can get these people home the next day and that they're able to resume all their functional activities within just a couple of days really gets them back to a fully functional status in just a matter of a couple of days.
And so someone who wants to pick this up, I mean, how's training like? It sounds pretty straightforward. We talked about it. Is there a lot of support staff that comes when you're first starting these cases? Is there any simulation models, or can people come to your lab or another lab to actually see a procedure being done?
Great question. So to their credit, Endologix has been very careful and judicious in rolling this out. And they have basically gone to the hospitals that participated in the study, obviously sort of had first cracks at it when it became available. And Endologix has a really robust and I think very thorough training program. So anyone out there who is interested in learning how to do this procedure and incorporating into their practice, they should contact their local Endologix rep. And there are training programs that are available all over the United States. I happened to do one, for example, in Dallas back in December. And it was a 1.5 day program talking about didactics. It also included simulation, virtual reality training. There was also a cath lab where you got to practice the procedure. So the training is actually quite vigorous and quite robust. And there are physician proctors who can be available if you want for your first couple of cases. So I think that there is a wealth of support and training. And I have to make a quick plug for the Endologix field specialists are really second to none. They do a great job. They know their product cold, and they will make sure that you are comfortable and walk you through it every step of the way.
Got it. And in addition, and this goes back to not the VAC committee or how to convince your hospital, but have you ran into any problems or heard of problems once you use the word bypass and then credentialing? Does that become a problem, especially for endovascular specialists, such as ICs and IRs like myself? Does that word bypass then get kind of conflicted or muddled in credentialing?
Well, James Michael Curley said it best, all politics are local. So that, I guess, will depend on particular institution in which you practice. But although it does use the word bypass, It's not an open bypass. This is all percutaneous. And if you are a advanced endovascular specialist who's used to doing ultrasound guided access, then this really shouldn't be a great departure from the skill set that you should already have.
Yeah. What's next for the device? What's next for DETOUR? Or we mentioned 3-year data. Any other trials going on or future endeavors?
Great question. Endologix is in fact going to be starting a post-market registry, and that'll be a nice opportunity to basically expand the scope of this procedure in terms of availability. And I think it'll be very interesting to see if the registry replicates the excellent results that were obtained in the DETOUR 2 study. I really think that they will. It is not a device that you're going to use on everyone, but for the really toughest cases, I think it's really been a godsend and offers our patients a nice alternative to something that is either going to be very high risk or for whatever reason is not going to be feasible because of their comorbidities or their lack of conduit. So it really is fulfilling a significant unmet clinical need. So it's nice to have another arrow in the quiver.
Yeah. Well, no, this has been great. I mean, again, so many questions about the device. I think we've gone through so many and hopefully that's answered a lot of the audience's questions. And it's really, I mean, that's the beauty of endovascular care and peripheral vascular disease in general. I mean, the technology is advancing. We're getting all these new techniques and devices. And sometimes I say to the skeptics out there that, how are you going to advance the field if you're, you got to think out of the box. And I think PTAB is definitely true out of the box thinking and a very cool device that's different from our other traditional ones. So Peter, thanks again for coming on the show. Is there anything else you want to tell our listeners?
To just be very careful, at least in the beginning of your experience with PTAB, really try to stick to the IFU. And again, take advantage of the superb clinical support staff. They will help review with you the imaging, and they want the procedure to be successful. And they're going to tell you if they don't think it's going to be a great PTAB, and don't try to push the envelope. It is a really breakthrough technology, but you have to respect it and just use it in the correct clinical setting.
Well, great, Peter. Thank you for being on the show. Thank you for giving all the pearls of wisdom. Really was a pleasure having you. Thank you.
Thanks. Really appreciate it, Sabine.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.